Hello everyone, I am Dr. Trupti and you are watching my YouTube channel Enjoy Biochemistry. In today's video, let's learn about estimation of serum creatinine, urine creatinine and creatinine clearance. At the outset, I am thankful to Mr. Sabir Kazi, technician at Department of Biochemistry, GMC Nandurbar for performing this experiment. At the end of this session, Phase 1 MBBS student shall be able to perform the estimation of creatinine in serum and urine sample independently in the undergraduate practical laboratory, and the student shall be able to calculate the creatinine clearance and interpret the results. In the first year MBBS, the quantitative experiment is a case based. So let's start with the clinical case scenario. A 50-year-old man was admitted in the hospital with complaints of loss of appetite, nausea, weakness and occasional vomiting. He gave history of getting admitted in the hospital for similar complaints 6 months ago and he was diagnosed with kidney disease. He was suffering from diabetes mellitus and hypertension from 10 years. On examination, he was anemic and his BP was raised. It was 160 by 100 millimeters of mercury. Laboratory investigation showed the low HB, that is 10 gram per deciliter. Fasting plasma glucose was increased, that is 180 milligram per deciliter. Postprandial glucose was also increased to 90 milligram per deciliter and blood urea was also increased, that was 70 milligram per deciliter. Now the question is, estimate the relevant biochemical parameter in the given serum and urine sample to assess the kidney function. Here urine output is also given, that is 1200 ml per day. So in this case, patient is already diagnosed with the kidney disease. He has the history of diabetes mellitus and hypertension, and investigations are also supporting that he has diabetes mellitus and hypertension, and one parameter of kidney function, that is blood urea, is already given here. So the other relevant biochemical parameter here is creatinine. So here we have to estimate the creatinine in the serum sample, in the urine sample, and also we have to calculate the creatinine clearance. Now let's see what is creatinine. Creatinine is a metabolic waste product which is excreted in the urine, and it is formed from creatine by removal of one molecule of water, which means that creatinine is anhydride of creatine. So one water molecule is released from the creatine to form creatinine. It is the non-enzymatic reaction and this occurs in the skeletal muscle. This creatine, it is stored in the form of creatine phosphate in the skeletal muscle, and this reaction is catalyzed by creatine kinase. This is called as Lohrmann's reaction. This creatinine can also be formed from creatine phosphate. So students, please note that creatine is stored in the muscle in the form of creatine phosphate. It is not synthesized in the muscle. Then where it is synthesized? It is synthesized in the two important organs, that is kidney and liver. One step of creatine synthesis occurs in the kidney and second step occurs in the liver. And creatine formation requires three important amino acids, that is glycine, arginine and methionine, that is GAM. So let's see the first reaction. In the first reaction which occurs in the kidney, glycine and arginine condense together to form guanidoacetate by the action of enzyme amidinotransferase, and here ornithine is released, and this ornithine can be utilized in the urea cycle as it is the intermediate of urea cycle. So in the first step of creatine formation, guanidoacetate is formed in the kidney. Then in the liver, there is transfer of one methyl group from the active methyl donor, that is S-adenosyl methionine, which is also called as SAM, and there is formation of S-adenosyl homocysteine, and guanidoacetate gets the methyl group to form creatine. So the formation of creatine occurs in the liver, which is then circulated and it reaches to the skeletal muscle, and in the skeletal muscle it is stored in the form of creatine phosphate. And in the skeletal muscle itself, creatinine is formed from the creatine by non-enzymatic reaction, and that creatinine is then excreted in the urine, and it is the good indicator of kidney function. Now let's estimate the serum creatinine by modified Jaffe's method. It is the fixed time and endpoint method. What is the principle of this method? Here, the creatinine in the given sample reacts with picric acid in an alkaline medium to form an orange color complex. Intensity of that color formed during the fixed time is directly proportional to the amount of creatinine present in the sample. The principle is same for both estimation of serum creatinine and urine creatinine. So the creatinine in the given sample reacts with the picric acid in alkaline medium to form orange color complex, and intensity is directly proportional to the concentration of creatinine present in the sample. Now let's see the procedure for estimation of serum creatinine, and this procedure requires alkaline reagent, that is NaOH, picric acid. Then by mixing 1 volume of picric acid reagent with 1 volume of alkaline reagent, we make working reagent. For creatinine, we require standard 2 mg per deciliter, and we require the unhemolyzed serum. Here we have prepared artificial serum sample, as this video is for the academic purpose. And we need 2 micropipettes for taking 1 ml of working reagent and the other for taking 50 microliter. So let's first take the 1 ml of reagent in the 3 test tubes, blank, standard and unknown. This is the serum sample. So let's add 1 ml of working reagent in the blank, then in the standard test tube, and then in the unknown test tube. Then we will take 50 microliter micropipette. First we will add standard for creatinine in the standard test tube, that is 50 microliter of standard in the standard test tube. Mix it well. Then add the serum sample which is artificially prepared in the laboratory, as this is just for the academic purpose for UG student. So add 50 microliter of sample in the unknown. Mix it well. And then we have to add 50 microliter of distilled water in the blank. So now we have 3 test tubes, blank, standard and unknown. Now incubate for 5 minutes at 37 degrees centigrade, and then we have to read the absorbance at 520 nanometer. So first we are calibrating the instrument, setting the OD to 0 with the water blank. Then we take the reagent blank, that is our B. We got the OD of 0.31 for blank. Then we take standard. We got OD of 0.82 for standard. And then for the unknown, we got OD of 1.22. So this is how we have to perform the procedure, and we get 3 ODs: OD of unknown, OD of standard and OD of blank. Now let's do the calculation with the help of ODs that we have got. The formula is serum creatinine in milligram per deciliter is equal to OD of unknown minus OD of blank divided by OD of standard minus OD of blank multiplied by 2, which is the concentration of standard here. We are putting all the values. OD of unknown is 1.22 minus OD of blank is 0.31. OD of standard is 0.85 minus OD of blank is 0.31 multiplied by 2, and we get the answer 3.3 milligram per deciliter. So the result is the concentration of serum creatinine is 3.3 milligram per deciliter. So to interpret this result, we should know the normal reference range. In males, the serum creatinine concentration is 0.7 to 1.4 milligram per deciliter, and in females it is 0.6 to 1.3 milligram per deciliter, and our result is 3.3, which means that the serum creatinine level is increased. Now let's see the procedure for urine creatinine. The procedure is same here, only the specimen is different, that is the diluted urine 1:100. Otherwise everything is same here. We have to prepare the working reagent by mixing picric acid and the alkaline reagent. So let's see how it is done. So for this we require alkaline reagent, picric acid, then standard and diluted urine. We prepared the reagent by mixing picric acid and NaOH. And we require 3 test tube, blank, standard and unknown. Here unknown is urine sample. We require the micropipettes. First we take reagent 1 ml in all the 3 test tube, blank, unknown and standard. Then we add 50 microliter of distilled water in blank. Then 50 microliter of standard in the standard test tube. Mix it well. And then 1:100 diluted urine sample in the unknown sample. Mix it well. Keep it for 5 minutes at 37 degrees centigrade and then measure the absorbance at 520 nanometer. First, calibrate the instrument with the water blank. Set OD to 0. Then measure blank, which was 0.31. Then standard 0.85 and unknown was 0.55. So we got 3 ODs here, OD of blank, standard and unknown. Now with the help of ODs that we got, let's do calculations. Urine creatinine in milligram per deciliter is equal to OD of unknown minus OD of blank divided by OD of standard minus OD of blank multiplied by concentration of standard, that is 2 multiplied by 100 as we have diluted the urine sample 1:100. Putting all the values, that is OD of unknown was 0.55 minus OD of blank 0.31 divided by OD of standard, which was 0.85 minus OD of blank 0.31 multiplied by 2 into 100. So it comes as 88 milligram per deciliter. So the result is the concentration of urine creatinine is 88 milligram per deciliter. And the normal reference range is, in the females it is 20 to 275 milligram per deciliter. In males it is 20 to 320 milligram per deciliter. We calculated the urine creatinine in milligram per deciliter. So we have to convert it into grams per liter. For that we need to divide by 100. And if you want urine creatinine in gram per 24 hours, so we have to multiply it by the daily urine output. We assume that 1.5 liter is the normal daily urine output. So it comes as 1.32 gram per day, that is per 24 hours. So the result is the concentration of urine creatinine is 1.32 gram per 24 hours. In the milligram per deciliter it was 88 milligram per deciliter, but for 24 hours it is 1.32 gram per 24 hours. And for this unit the normal reference range in males is 1 to 2 gram per day. In females it is 0.8 to 1.8 grams per 24 hours or per day. For clearance calculation, we require both serum creatinine and urine creatinine, but before that let's see what is this clearance. The clearance is defined as the volume of blood or plasma completely cleared of a substance per unit time, and it is in the ml per minutes. And this clearance measurement, it is a test of GFR, that is glomerular filtration rate, and it is the index of severity of renal damage. GFR is the volume of plasma that is filtered by the glomeruli per unit of time. This GFR cannot be measured directly, so it is estimated from the clearance of filtration marker. There are various types of clearance tests like urea clearance, inulin clearance, creatinine clearance, etc. The normal GFR in young adults is about 120 to 130 ml per minute per 1.73 meters square. So what is creatinine clearance? It is the volume of blood or plasma completely cleared of a creatinine per unit time, and it is the unit is ml per minute. So creatinine clearance is equal to milligram of creatinine excreted per minute divided by milligram of creatinine per ml of plasma. It is calculated by the formula clearance is equal to U multiplied by V divided by P. What is this U? It is the urine creatinine in milligram per deciliter P is the serum creatinine in milligram per deciliter, and V is the ml of urine excreted per minute, which is also called as rate of urine flow. To calculate creatinine clearance, we have urine creatinine 88 milligram per deciliter, serum creatinine 3.3 milligram per deciliter. Now we have to calculate V, that is rate of urine flow. Normally we consider daily urine output as 1500 ml, and we divide it by 24 multiplied by 60, that is 1440, and we get the rate of urine flow as 1.04. But in this case the daily urine output was given, which is 1200 ml, so we divide it by 1440 and we get rate of urine flow as 0.83. So now putting all the values in the formula, urine creatinine, that is 88 multiplied by rate of urine flow 0.83 divided by serum creatinine, that is 3.3, we get creatinine clearance as 22.22 ml per minute. The normal range is, in males it is 85 to 125 ml per minute, in females it is 75 to 115 ml per minute. So here in this case creatinine clearance is decreased. Now let's interpret the result. So we know that the patient is suffering from the kidney disease and he has history of long-standing diabetes mellitus and hypertension. We got serum creatinine level is increased, that is 3.3 milligram per deciliter, and creatinine clearance is also reduced. So this is the case of chronic kidney disease due to diabetes mellitus and hypertension. Which are the various causes of decreased serum creatinine level? As it is produced in the muscle from creatine, it is decreased in conditions of low muscle mass, malnutrition if the patient is taking medicines like thiazide and vancomycin. The causes of increased serum creatinine are old age, various renal diseases like glomerulonephritis, pyelonephritis, renal failure, urinary obstruction, congestive cardiac failure, and various medicines also will lead to increased serum creatinine like amphotericin B, captopril, cephalosporin, kanamycin, etc. There are various advantages of estimating serum creatinine as a marker of or indicator of kidney function. It is the endogenously produced compound which is formed in the muscle by non-enzymatic reaction from creatine. It is spontaneous production. It is constantly produced and excreted. About 2% of creatinine is formed from the creatine in the muscle and it is excreted. That production is constant. It does not fluctuate much, so the blood level will not fluctuate much. It is not bound to the plasma protein and it is not affected by age, diet or exercise. There are some disadvantages of using creatinine as indicator of kidney function. Creatinine is completely reabsorbed, but 10% is secreted in the tubules, and the tubular secretion contributes to 10% of total creatinine excretion by the kidney. There is no increase in serum creatinine until the GFR is moderately decreased. So early kidney failure is not detected by using serum creatinine, and serum creatinine level starts increasing only after 50% of kidney functions are lost. There is insensitivity to moderate decreases in the GFR, which is called as creatinine blind GFR area, which is about 40 to 70 ml per minute. And serum creatinine may not be a good parameter for determination of a GFR at lower levels of glomerular function. So these are some disadvantages of using creatinine. Nowadays, calculation of creatinine clearance or GFR does not require the urine creatinine level. So the estimation of creatinine clearance and GFR is done by using only serum creatinine level, and that eliminate the need for timed urine collections. And this estimated GFR can be calculated by the various formulas. Various calculators are available, and by putting the values in the calculator we can get estimated GFR. So one of the formula is Cockcroft-Gault equation, where creatinine clearance is calculated as 140 minus age in years multiplied by weight in kg, and in case of female it has to be multiplied by 0.85 divided by 72 multiplied by plasma or serum creatinine in milligram per deciliter. So here urine creatinine is not required. This is the estimated GFR. There is one more equation which is more accurate, that is MDRD equation, that is modification of diet in renal disease. So calculator is available for this, and eGFR can only be used accurately in patients with chronic kidney disease and not on healthy individuals, not children and obese people. There are various other equations also which is re-expressed MDRD 2 equation, CKD EPI equation, Mayo equation. Chronic kidney disease has 5 grades. The grade 1 shows minimal damage with the normal GFR. Here GFR is more than 90. Second grade is mild damage with slightly low GFR, that is 60 to 89. Moderately low GFR is the grade 3, 30 to 59 is GFR. Severely low GFR is 15 to 29, that is the grade 4, and kidney failure when the GFR is less than 50, that is the grade 5. So here it shows the 90 to 120 is the normal GFR, 60 to 90 shows early stage kidney disease, 15 to 60 shows the kidney disease, and 0 to 15 shows kidney failure. And chronic kidney disease is defined as when the GFR is less than 60 ml per minute per 1.73 meter square for 3 months or more with or without the kidney damage. What will be the picture in acute kidney injury or acute renal failure? There will be rapid rise of serum creatinine with low urine output, and this is associated with the oliguria, hyponatremia, hyperkalemia, decreased calcium level, increased phosphate level and increased uric acid level. The onset of the disease is the swift and it is the fatal one. Serum creatinine here can take days to show an increased level. There is one novel biomarker of tubular injury which is called as urinary neutrophil gelatinase associated lipocalin or UNGAL. This UNGAL is very useful when serum creatinine level is not increased in case of acute renal failure. Cystatin C is the excellent GFR marker. It is 13 kilodalton non-glycosylated protein which is the extracellular cysteine protease inhibitor present in high concentration in the biological fluids like breast milk, tears, saliva, but expressed in virtually all organs of body. It is produced at constant rate, freely filtered by the glomeruli and completely reabsorbed, degraded in tubules, and that's why it is the excellent GFR marker. There are some advantages of cystatin C over estimation of serum creatinine. Cystatin C is not dependent on age, sex, muscle mass or inflammatory processes. Creatinine level is increased only when more than 50% of renal damage is present, so it does not indicate the early kidney dysfunction. But cystatin C is sensitive to changes in the creatinine blind area of GFR, that is 40 to 70 ml per minute per 1.73 meter square GFR. There is no tubular secretion of cystatin C like serum creatinine. It is extremely sensitive to minor changes in the GFR and it is sensitive early marker for kidney damage. Now let's see some most likely question asked in the practical exam. The first question is, what is creatinine? It is the anhydride of creatine. How it is formed in the body? It is formed from creatine in the muscle. It is the non-enzymatic reaction, but creatine is formed in the kidney and liver and then it is stored in the muscle in the form of creatine phosphate. Mention the normal reference ranges of serum creatinine, urine creatinine and creatinine clearance. Why serum creatinine is better indicator of kidney dysfunction than urea? Because the serum creatinine level are not influenced by the age or dietary intake, and this serum creatinine it is freely filtered, it is completely reabsorbed, only some amount is secreted, the rate of formation is constant, so the blood level do not fluctuate much. So these are the various advantages of estimating serum creatinine and it is a better indicator of kidney dysfunction than the serum urea. Define clearance and how creatinine clearance is calculated. Mention the advantages and disadvantages of creatinine clearance. Define GFR, mention various clearance tests. Mention the common tests done in laboratory to assess kidney dysfunction, and first we have to mention about the serum urea and serum creatinine. Explain the role of cystatin C as a glomerular filtration marker. This is very important question. And mention various conditions associated with increased and decreased serum creatinine level. So I hope this video on estimation of serum creatinine, urine creatinine and creatinine clearance will be helpful to you. Thank you for watching and happy learning.